Welcome to this morning's session on assessing quality in telehealth initiatives. My name is Natassja Manzanero, and I'm a program coordinator for the 14 telehealth resource centers. I work in the Federal Office of Rural Health Policy, Office for the Advancement of Telehealth, and I really thank you all for being here today, especially after last night's big NCAA game. I know I was up late last night watching that, so I'm a little sleepy right now. And I also really thank you for coming to this session because my boss, Bill England, has a session at the same time on assessing quality in telehealth technologies. So really thank you for being here in this room today. So I wanted to introduce my esteemed panel. We actually have 3 folks in the room and 1 person dialing in remotely. And I'd like to go ahead and introduce to you our panel of doctors, actually. We have Dr. Marcia Ward from the University of Iowa, Dr. Atif Mehrotra from Harvard University, Elizabeth Krupinski from Emory University, and Bonnie Britton from Reconnect for Health. So I'm going to go ahead and ask all of our panelists, starting with Dr. Marcia Ward, to give a brief background and overview of your work.
And Bonnie just joined us on the screens. Good morning, Bonnie. I'm Marcia Ward.
Good morning.
I'm a professor at the University of Iowa and director of the Center for Health Policy and Research and interim director of the Department of Health Management and Policy in the College of Public Health. I also direct the Rural Telehealth Research Center, and that is a HRSA-funded, telehealth-focused rural health research center. And part of what we do is collaborate with the University of Southern Maine and the University of North Carolina, Chapel Hill, to do research that HRSA's Federal Office of Rural Health Policy hears from Congress needs to get done. And so boost evidence-based research. Before that, I've been at the University of Iowa for 20 years. Before that, I was for 20 years at SRI International in Menlo Park, California. And currently, I am serving on the National Quality Forum Telehealth Framework Committee, and I have the honor of co-chairing that. So I'll talk a little bit about that as we get into the session.
I'm going to say go Tar Heels.
Tar Heels.
Hi, everyone. My name is Atif Mehrotra. I'm a physician and researcher at Harvard Medical School in the Department of Healthcare Policy. I also work, I'm a physician, and I work at the Beth Israel Deaconess Medical Center, also in Boston. My work comes framed a little bit differently, which is about, I think about my work as innovations in delivery. And there's so much excitement, interest in different innovations like telehealth, but others. And while there's so much excitement and sometimes hype, I see my role as being someone who can, from a research perspective, evaluate what is the impact in terms of cost, quality, and access. And through that light, I've done work on retail clinics and urgent care centers and symptom checkers. And today I'll be talking a little bit later about some of my work on direct-to-consumer telemedicine.
Hey, hi everyone, I'm Elizabeth Krupinski. I am a professor and vice chair of research at Emory University in the Department of Radiology. I've been there since late 2015. And there I do a lot of work with our virtual patient care team, which I just got involved with when I moved there. Prior to that, I was at the University of Arizona for 23 years, and I'm still associated with them as the co-director of the Southwest Telehealth Resource Center. We cover Colorado, New Mexico, Nevada, Utah, and whichever one I didn't mention. There's 5 of them, 5 states. It's early in the morning. And I am also the Associate Director of Evaluation for the Arizona Telemedicine Program, of which the Southwest Telehealth Resource Center is a subsidiary. My background is I'm an experimental psychologist, and I've been involved in evaluating interfaces between humans and technology since before 1987, when teleradiology really started, and we made that transition from film into digital. And a lot of the questions revolved around, well, how the heck do radiologists deal with all this technology? Can you render accurate diagnoses, et cetera, et cetera, et cetera? And that just echoes throughout the past, 30 years of telemedicine or so. And so I do a lot of evaluation from the perspective of an experimental psychologist, looking at human factors perception, cognition, and how all of that interplays into an integrated decision-making process in the telehealth arena.
Great. And we have Bonnie on the screen. Hey, Bonnie.
Sure. Hey, my name is Bonnie Britton. I'm the co-founder and executive director of Reconnect for Health. I'm a master's prepared nurse and have been in the remote monitoring, patient monitoring space. In May will be 20 years. Have been very involved at the national and international level with remote patient monitoring. Have scaled several programs, several large programs. I am proud to say that I'm a board advisor for MATRC and also a fellow of the American Telemedicine Association. And go Tar Heels!
Great, thank you all. So we have kind of made this panel a little different. We actually decided to go ahead and divide the questions and the answers into 4 topic categories. But before we start, I wanted to start with a quote from Donald Berwick, who was a former CMS administrator who was one of the pioneers of the FSPIE. He says, "The best way to get a good idea is to get a lot of ideas. There is a right thing to do with regard to quality of care, improve it. If that takes courage, so be it." So today that's kind of one of our goals of how we want to talk about quality and telehealth initiatives. So we kind of put our, I guess, key topics into 4 categories based on the vast background of our panel today. So the categories are clinical outcomes, human factors, satisfaction and usability, financial ROI, and policy. So I'm going to go from left to right and ask Dr. Marsha Ward to kind of talk about the clinical outcomes aspect of quality improvement for telehealth.
So to begin with, a lot of what we're going to talk about today has to do with how you measure things, metrics. And so metrics are standardized measures, and if they're good, they've been clearly defined, including if it's a rate, the numerator and denominator are very clearly defined who falls into those populations. They're standardized because they're so clearly defined. People know what these are. You can do research and publish on this, and then someone else can come through and replicate your research or compare their findings to yours. And so metrics that are standardized are a beautiful thing. In terms of clinical outcomes, so clinical outcomes are the end results of care that's delivered. And when people talk about metrics, clinical outcome metrics are like put up as the best thing since sliced bread. That's what we would like to really be able to show, that telehealth is equal to or better than a comparison in terms of those clinical outcome metrics. So what are outcome metrics that might be suitable for evaluating in terms of telehealth? There's tele-ICU. So when that's used in an ICU, people are looking at complications, adverse events, and with the idea of continuous monitoring of at-risk patients, it's possible that that tele-ICU could actually reduce the occurrence, the rate of adverse events like post-surgical complications. Excuse me. Another example of this. Thank you. I apologize for that. Another example of that is telehome care, and what we're looking at there often is, can we avoid a rehospitalization? And so possibly, I'm sorry. Thank you. I'm going to do a good cough here. Telemental health, other sorts of chronic condition monitoring in terms of telehealth, all of those is the idea of maybe preventing a hospitalization. So those are the sort of clinical outcomes that we're particularly interested in. Now, often we can't get data to actually look at those, or there's challenges in getting the data to look at those and evaluate those in terms of telehealth in a comparison group. So the next tier down would be process measures, clinical process measures. And again, for standardized metrics, these should be very clearly defined, and a lot of work has been done in this field. So CMS started with their core measures, there's PQRS, MIPS is coming out with measures that we'll all be living with going forward. And so a lot of work goes into identifying these measures. They're evidence-based. Everybody knows what they are in the domain that they're working in. Everybody working in a hospital knows what those standardized measures are. The hospitals are collecting data on that and submitting it to government agencies. Private payers are using the same sort of measures. There's a lot of buy-in for these because they've been vetted so completely. And so, again, being able to collect data on that, there's some real advantages because they already exist. So what sort of data is out there? With these standardized measures, as I said, a lot of the data already exists and it's getting reported at the hospital level, nursing home level, that sort of thing. A lot of these measures are also getting built into electronic health records. And so companies that are making electronic health records or are creating tools within those will build these measures into those so that we published work a long time ago in the VA system. They had these measures already in terms of checklists that a provider would go through and see, oh, this is a patient with diabetes. When was the last time that I got a hemoglobin A1C? I need to check that, or I need to check a reason why I'm not doing that to proceed with care. And when you have a system like that, as we were able to show in a lot of people, you really boost up adherence behavior. So that sort of data may already exist within certain systems, and then you can harvest that data. Another possibility, and we're using this a lot, is we're working with a telehealth hub. And so the organization that is providing tele-ICU to a group of remote hospitals, they've got special data. Usually they log in all the patients. We've been publishing a lot on tele-ED. And they log every single patient when their tele-ED system is activated, and they collect standardized measures that they have worked through and created, but they've now been collecting them for years. And a lot of that is timeliness data, and that could be a very important process measure, the timeliness to care. And we'll be able to look at some things in terms of stroke patients and other sorts of patients on what sort of care was delivered and what was the delay in terms of delivery or the timeliness of delivering that care. And so there may be the opportunity of collecting that from a hub. Claims data is another possibility. And so Medicare claims data, Medicaid claims data. Gilman and Stensland published something a number of years back when they looked at, was telehealth noted in outpatient Medicare claims, and found out that it was really at a very low, unbelievably low rate. And so there's a real caveat with using the claims data. Is telehealth being identified and coded? We're now looking at Medicaid data. Our partner at University of Southern Maine has gotten a nationwide sample of Medicaid data, and they're looking to see how completely telehealth is coded within that. And if it is, with HRSA's sponsorship, we'll be looking at parity, non-parity states and doing a comparison, especially for telemental health. Another question, so that's what data sources. When you look at data, really what we're looking at is telehealth effective? That's the question if we're looking at clinical outcomes that comes to mind that we're often addressing. And in order to do that, randomized clinical trials are the gold standard, but I think they are incredibly difficult in telehealth. They are so artificial in much of what we do. And so the alternative is some sort of a pragmatic trial. And we've been looking at a number of different places that provide telehealth services. The catch is we can identify through their systems everybody who got the telehealth service. And in the tele-ED, that's 3 to 4% of patients that come into a rural ED. And as we've been able to show with looking at a trauma registry and things, they're definitely the more severely injured patients. And that's true across all sorts of clinical conditions that we're looking at. So how do we draw a comparison group, same setting, that did not get tele-ED? They're not going to be as severely injured, and so that creates some real challenges. And we are struggling with that currently in one of our HRSA-funded projects of how to pull that sample in, especially if they haven't gotten a standardized, like for stroke, there's a standardized NIH scale for stroke severity. Rural hospitals don't do that. And so it doesn't exist in the data. And so, again, trying to find out, can we come up with some way to be able to pull a comparable sample? that did not get the telehealth service, but is in a place where telehealth is potentially available. So that selection bias is a huge factor. A clinical outcome measure that I hear a lot that is very popular is mortality. So mortality obviously is very easy to define, and it's documented 100% in records. The catch is with mortality, it's rare, and so in order to do research on a very rare event, that creates some real challenges. But also there's a lot of selection bias that's potential. We published a paper a long time ago looking at AMI, acute myocardial infarction deaths in small rural hospitals in Iowa compared to those that were in larger hospitals, found a really high rate, tried to do standard risk adjustment to it. That didn't really do the trick. We had to do some other fancy schmancy statistical analysis, and what we found out was the healthier patients, again, were getting transferred to the academic medical centers. They were good candidates for surgical procedures, and the patients who were left in the rural hospitals were often what we would classify as hospice patients, but that doesn't exist in a rural community. So that's where they were, and lo and behold, in the rural hospitals, they had a higher mortality rate. So that sort of bias is what can creep in that is a real challenge for trying to do comparisons. So the last thing is, I mentioned the NQF. So NQF, the National Quality Forum, goes through an extensive process of identifying measures and clinical outcome measures at the top of their wish list. They're currently putting together a group of telehealth folks, I didn't want to say experts, but folks, and working through to try to identify what sort of measures are appropriate for telehealth. And the domains that we are talking about today are some of those, like clinical and human factors and financial and policy domains that they're working through. Those are the concepts that we need to identify measures for. And then that organization, NQF endorsed measures, if you're used to those are the ones that have really gone through the testing and are adopted then by CMS and other organizations. So stay tuned. Hopefully somebody's going to do all this work, and we'll have a great set of measures to be able to use as we evaluate going forward.
Great. And I think that report is due in September. So
for the framework, and then there's the next
yes,
chapter.
There's the next generation. Yeah, thank you so much. Dr. Krupinski, did you want to go over kind of the human factors, satisfaction, and usability of quality and telehealth initiatives?
Yes, thank you. It's looking at things at a slightly different perspective. I tend to look at sort of a systems approach, not looking necessarily at clinical outcomes, which I do, but looking more at sort of the interfaces, again, between technology and people and people and people. And when we all started telemedicine, I think we all started with the field of dreams. If you build it, they will come. And it's all just going to be happy and it's going to work. And very quickly we all realized, ooh, this is even below AAA. We're not even getting to the point where they're going to come watch our games because it wasn't working. And I think a lot of what it wasn't working was with the human factors. And so let alone clinical outcomes, if we couldn't even get to the point where we're seeing the patient effectively, the clinical outcomes aren't going to come out of anything that doesn't work. And so it's important, I think, to determine in advance what metrics are really appropriate for what you're doing. There's a lot of metrics out there, both in terms of usability, satisfaction, clinical outcomes, but I think you can't just say, tell me what to do and I'll just measure everything, because we all found out that doesn't work either. I remember when I started out, I wanted my site coordinators to give me like 50 different parameters, and it's like, well, why can't you do this? Oh, because we have, 20 million patients in a day and the days only last so long. And I'm like, oh gosh, science. Okay, well, forget that. Let's narrow down and figure out what are the key things that we need to study. And so I think that's really where people have to start out, is what is the question really that is most appropriate for the case scenario that you're working in and that you want to, in a sense, make your impact, to your point, about. Is it going to be clinical outcomes, or is it going to be sort of a more program-oriented metric? and that you're able to integrate telemedicine into your healthcare enterprise. And that's where the human factors and the satisfaction, usability, et cetera, come into play. So not all metrics are appropriate for every situation. And that's kind of hard to get across to people because what most people are looking for is the easy answer. Here's what you need to do. Just get these pieces of information and you will have an assessment program in place. Well, it's just unfortunately not that easy. And it takes a little bit of going back and forth to figure out which metrics are the most appropriate. People tend to look at things like satisfaction. I think satisfaction has been done to death. Very rarely do people say they're unsatisfied because they're getting something, which is better than nothing. And unless the technology just absolutely, completely fails, everybody's pretty happy. What you can look at, however, from sort of a more human factors perspective that takes satisfaction a bit further, perhaps is, did the patient learn anything new from your encounter? Did they learn something about their condition or their health care or their treatment that they didn't know before? And that's what led to the increase in satisfaction, perhaps. So I think we're at the stage now where we can go a bit further and utilize different types of surveys and different types of satisfaction metrics than we have in the past, simply saying, were you happy? Were you able to see the person? Were you able to hear them? And unfortunately, I keep seeing, I'm on the editorial board of a number of journals, and I keep seeing these studies coming out. Are people afraid of technology? Should we get into telemedicine? Oh, all our patients are happy. We know that. It's not publishable. It may be useful for your own internal program to find out if everybody's still happy, but we don't need those types of surveys to be published anymore. What we do need, like I said, is more information about what is the impact of the telemedicine encounter on the patient. Not only in terms of outcomes, but in terms of their satisfaction, their well-being, their quality of life. So all of these are surveys that exist for general medical encounters. And there's no reason why we can't simply utilize them in telehealth as well. And I highly encourage that you do so. When it comes to evaluation and looking at people's satisfaction and diagnostic accuracy, and there's a whole lot of aspects that you can evaluate in a telemedicine program, and not just outcomes and satisfaction, but you can look at changes in the decision-making processes of your clinicians. Are they impacted in the way they render their decisions simply because of the telemedicine encounter? And I'll give you an example in a minute, but there's a simple approach that you can utilize without having an MD or an MPH or a background in epidemiology. And you might be saying, well, I don't do assessment or evaluation, that's science. It's not science. There's a lot you can do. And I think the three-pronged approach is decide what your indicators are. What is it you want to measure? What are the metrics? Is it simply something like a reduction in A1C levels, a change in spirometer readings? Is it a change in body mass index or whatever? Something that is readily measurable, that is an indicator of some sort of progress in the patient. Second thing, once you have those indicators, you can develop targets. For example, I want to see in 25% of my borderline diabetic patients, 10% decrease in A1C levels over a 3-month period. Very easily measurable. They just come back in 3 months and you get 2 numbers. Out of that, you get outcomes. And the outcomes simply are, did you meet your targets for those indicators? And if you have positive outcomes. Not only is it reportable potentially in a journal, but it's reportable to those who are running your telemedicine program or financing it and so on. And you have something absolutely measurable that you can go out and say, we have outcomes, whether they're clinical outcomes, satisfaction outcomes, or whatever. Now, getting back to the one that I mentioned in terms of looking at the clinicians or the healthcare providers and their decision-making processes. For example, we had a store and forward teledermatology program for years in Arizona, and we started out really hot and heavy. It was one of our first clinical specialties, and the rural docs were, oh, we got to use it, and they were using it. And then after about a year and a half, it was like we started to see our volumes going down, and we were like, uh-oh, what are we doing wrong? What are we doing? And we couldn't think of anything that we had changed. So we reached out to the providers and they said, no, you're not doing anything wrong, but we kept sending these cases and getting back the right answers and knowing what to prescribe. Well, now we know what they are and we know what to prescribe. We don't need you for those anymore. And we were like, oh, okay, that's good. So that is something you can measure as well. That's a human factors aspect that most people don't think about. And finally, again, there are a ton of validated surveys out there. You don't have to reinvent the wheel to get good metrics. And they don't just have to be telemedicine measures and metrics and surveys and so on. It's healthcare. It doesn't matter that it's tele. That's not the point anymore. So the WHO quality of life, there's the TAM, which is the telemedicine assessment metrics, but you don't have to call it that anymore. You can use any of the surveys that are out there for general healthcare assessment and utilize them within the context of telehealth, and they're perfectly valid and useful as well, just in a different scenario. So I think from the human factors perspective, there's an awful lot you can do that will tell you how well you're integrating healthcare into your enterprise. And that really is the key, is getting the people involved and doing it in the right way. And once you've got that accomplished, the clinical outcomes and the policy and the return on investment, I think all of that's going to come out of a well-oiled machine. And if you get that going first, you're pretty much golden after that, I think.
Excellent. Thank you so much, Dr. Krupinski. Next, we'll have Bonnie Britton do a little bit about financial ROI. Bonnie?
Okay, thank you very much. A financial return on investment is always an important factor. We as clinicians, we love to see improvements in patient outcomes, but the bottom line is you have to have a financial return on investment for the organization. And the financial return on investment is really going to be dependent upon the organization. If you're a home health agency, your financial return on investment and what you measure, how you measure that is going to be different than if you're a healthcare organization or a healthcare system, I should say. One of the things that is absolutely key is identifying the patient population that's going to be the most critical to be able to demonstrate a return on investment. What I mean by that is I've worked with many healthcare systems, and everyone seems to know in the beginning the patient population they want to focus on. For an example, I was working with a large academic medical center, and they were pretty convinced that they knew the patient populations they were losing the most money on. They thought those were Medicare patients with chronic obstructive pulmonary disease as well as heart failure patients. And what they found when they actually when we worked with the chief financial officer to pull the data on their losses, their number one losses were self-pay patients. And on average, they were losing around $9,000 per patient per hospital readmission. And the majority of that money had to be written off at the end of the year. So number one, it's very, very important to validate the patient populations where you're losing the most money. And then secondly, it's critical to work with the chief financial officer or the finance department to, number one, make sure that they are committed to pulling the data to identify the critical patients that you need to be focusing on for your financial return on investment, as well as a firm commitment that as you're moving forward with your program, that you are, that finance department will pull the data that you need. For most health systems, the data that you're going to need to pull include hospitalizations, what are the costs, the charges, as well as the reimbursement for those hospitalizations. Less than 30-day hospital readmissions is also an important factor for Medicare patient population. Hospital bed days. If you can decrease the number of bed days that a patient is in the hospital, then you are contributing positively to the bottom line. You also want to look at ED visits as well as the cost charges and reimbursement for that. And that needs to be a long-term commitment by the organization and the finance department to provide that data on a routine basis. Unfortunately, because we work in healthcare, it's not possible to always do randomized controlled trials that we would like to be able to do. So in looking at your return on investment from a financial perspective, the patient needs to either you need to have the patient serve as their own control point, or you need to have a comparison group. For an example, at Invited Health, we implemented a large remote patient monitoring program for patients being discharged from the hospital. These patients we approached, we conducted a PAM survey on them, patient activation measurement score, to determine patients who were the most or the least engaged in their health care. And after doing that, we went in to get consent for the patient. We had a group of heart failure patients who agreed to the program. They were discharged from the hospital and they were admitted onto the remote monitoring program. Then we had a group of heart failure patients who agreed to the program, were screened, enrolled into the program, and agreed to the program. But when we went to the home to do the installation of the equipment, they refused. For that group of patients, it was a small subset of patients, we were able to have a control group for heart failure less than 30-day readmission. And we're able to demonstrate that the patients who participated in remote patient monitoring, their heart failure readmission, less than 30-day readmission rate was 7% as compared to the patients who enrolled and then refused the remote patient monitoring program. Their less than 30-day readmission was 28%. So when you take that information and subgroups and can analyze it and compare, that is very positive. But a lot of times you're not going to be able to do that, and you'll need to use the patient as their own control. Thank you.
Thank you so much, Bonnie. And last but not least, we'll go to Atif to talk about policies around quality measurement for telehealth.
Yeah, so I think the title of this session is Assessing Quality in Telehealth. And I think I'm going to echo the other panelists in sort of challenging that basic premise, whether that's the right way you should tackle this question. I'll tell you a quick story. As background, I used to also work at RAND, and we did a lot of work on quality measurement. So a large health system said, hey, can you come in and help us think about how we should measure the quality of our telehealth program? Very big system. They had about 22 or 23 different lines, from tele-ICU to tele-prenatal care, et cetera, teledermatology. And as we went through that system, our basic message back to the program leaders was, don't think of telehealth specific metrics. It really was that the health system leaders, policymakers, they don't care if it's telehealth versus something else. They want to know, what's the care like compared to other visits that they have, and if they're going to be in a physician office, an emergency department, wherever else that might be, use the same metrics. And also not necessarily always about telehealth versus, whenever possible, was the whole system like in terms of that, and that includes telehealth, but it could be incorporated there. So if there's one message that I think I'd really want to emphasize to you, again, echoed by others, is don't think of telehealth specific metrics, think of quality metrics in healthcare. And there is a robust literature, many metrics out there that are used for measuring quality. Don't make something up on your own. Go to NQF, go wherever it is, specific to the clinical topic, and choose those metrics. So that would be the key metric. And then also don't collect data that's unique to your program. Collect the data that is being used for those metrics in other places, electronic health records, claims data, wherever else it might be. So to illustrate that, let me give you some, talk about some work we've done in the past on direct-to-consumer telemedicine. And we've done some work both looking at, within one health system, some e-visits where they were introducing those as another offering to their patient population. That was data that we collected from the electronic health record. So we collected electronic health record data on all the e-visits, all the visits to urgent care centers within the system, all the visits to primary care physicians in the system, and the ED. And we just said, okay, give us all those things, and those are easily accessible. The chief quality officer in that system was collecting these data already, and so we were able just to add in some data that we were able to pull. We've also done some work and published on Teledoc and other direct-to-consumer telemedicine, and there we partnered with a large health plan and got data from claims to look at that. And so what are the quality metrics we use to evaluate these telehealth programs? Well, we used it based on the clinical topics. So in both cases, what were the things that people were coming in for? Or getting care for, and not coming in for, getting remotely. Acute respiratory illness, urinary tract infections, back pain. And so we use those metrics that were already established by NQF and others to look at those areas. And those are based typically on, for acute respiratory illness, we know there's a large problem in the US healthcare system with antibiotic prescribing. So both antibiotic prescriptions written as well as broad spectrum antibiotics. There's a concern that physicians like myself, are too quick to turn to a broad spectrum antibiotic. And whether they were following the guidelines. So for pharyngitis, are you following the Infectious Disease Society of America guidelines on testing for pharyngitis? Or for the urinary tract infections, similar guidelines existed. For example, there the guidelines said that if a woman was having recurrent UTIs, you need to test with the urine culture because of concerns about resistance. So what do we find? I mentioned a couple of the pieces yesterday, but I'll emphasize them and go into a little bit more depth. The work on antibiotic prescribing that we found was that it mattered in which setting we were looking at. In one case, we found that the rates of antibiotic prescriptions written over a telehealth platform compared to an in-person visit were about the same. In the case of the large health system, we found concerning data showing that antibiotic prescriptions, the prescriptions were more likely to be written over a telehealth platform, and that raised some concern. And in that case, we looked at primary care visits by those same doctors in person versus telehealth. And in both cases, we found data related to the overuse of broad spectrum antibiotics, and those rates were higher via telehealth. In the area of testing, and this is what we often think about guideline concordant testing, we found that, again, not surprising, I think, that the telehealth visits were much less likely to be associated with a test. And that's either good or bad depending on your perspective, and I think more importantly, the clinical area. In the setting of pharyngitis for kids, we thought it was inappropriate because this was an important thing that was directed by the guidelines. Or for recurrent UTI, we found that providers were less likely to get that appropriate urine culture. But I also should mention the opposite, which is for all the back pain visits that are occurring, the docs were much less likely to order CT or MRI if it was a telehealth, and that was good. Because we found that at in-person visits, they're much more likely to order those inappropriate tests. And so in that particular case, it was actually very useful to not have a lower rate of testing. So it kind of gives you an example of using evidence-based guidelines, the metrics that are already in existence, and of just applying those to the telehealth platform. And in this case, we did a comparison of telehealth versus those other areas. Do want to come back to a couple of quick points that, again, I mentioned quickly yesterday, but just wanted to emphasize. The first was saying that in some cases the telehealth, for example, with antibiotic prescribing, was equal to a physician office visit is damning with faint praise. the rates of antibiotic prescriptions at in-person appointments was terrible in the healthcare system, both within that system but nationally. And so when we think about that metric of equal to in-person visits, I always have to, like, you can pat yourself on the back for like a second, but then really the key question is, how do you improve quality above that? Because the current baseline is so terrible that I'm not sure it's that useful to compare. On the population side and the cost side, I also wanted to mention a couple of quick studies we've done, again, on direct-to-consumer telemedicine. And there I want to emphasize that if I was to give one piece of advice, was to not focus on the cost of the visit itself alone. I think we need to think much more broadly about it when you measure the cost impact of telehealth. In the case of direct-to-consumer telemedicine and these e-visits, I felt it was very important to look beyond that visit, to look at follow-up visits, the tests that are ordered, prescriptions that are written, because that's really from a population or societal perspective the key area. And also, as I again mentioned yesterday, the idea that we also need to think about this at a population level, not the visit level. So how many visits are occurring across the population? Is the introduction of telehealth increasing the number of visits and therefore spending? So as much as you can, look at it from that perspective. So to summarize, I think the key message that I would emphasize to all of you when you think about measuring the quality of telehealth is, don't think about it that way. Think about it as, how do I measure the quality of care for this clinical problem that is being treated by telehealth? And then use the same metrics that are already being collected, that are validated by other NQF and other forums, and apply those to your telehealth platform.
Great, thank you so much, Dr. Mayorta. And we're having so much fun on this panel, I didn't realize we only had 15 minutes left. And I have a question for each of the panelists, and I promise everyone in the audience will have time for at least one or two questions at the end. So I'm going to go ahead and start with my question to Dr. Marshall-Ward. What kind of data should be collected in a telehealth program as it relates to clinical outcome measures that can be used for evaluating telehealth? And I know you addressed some of these topics earlier, but I guess kind of honing into some of the specifics.
And building off of what other panelists have said, so part of the question here is, why are you collecting data? And I'm a researcher, I collect data so that I can publish that data, and we need to build the evidence base to support quality measures, care that's provided. We did a systematic review and published it a couple of years ago on tele-ED. There were only 50 studies on tele-ED, a huge spectrum, and 2/3 of them were really poorly designed studies. So there definitely does need to be more evidence that's generated. And so if you're in a position to be able to harvest data from your system and publish it, I encourage you to do so. But another whole reason why you collect data is for internal reasons. And Elizabeth and Natassja gave examples of that. If your telehealth utilization is going down, finding out why that is. And we've seen that in looking at teletrauma, and the rural providers were learning from the telehealth consultation, and consequently, they weren't pushing the button to activate it again, and that's a wonderful thing. So internally, collecting from a systems level and not just looking at the telehealth service versus when the button isn't pushed or something, but looking more broadly at a system level to see how is care delivered. If telehealth is for early on more severe patients and then that drops off over time, what are the compensatory mechanisms that are going on within your healthcare system? And so that's one thing to look at broadly. And another thing is, and Bonnie referred to this, often you collect data because you've got a problem. And so if you've got a problem, if you realize you don't have an ROI on something that you thought you did, then drilling down into that is another good reason why you collect data and you look internally to do that.
Awesome. Thank you so much. Dr. Krupinski, in a similar vein, what kind of data should be collected in a telehealth program as it relates to metrics and surveys that you mentioned earlier to obtain useful program outcomes?
I think, again, I just want to stress the fact that it's got to be appropriate to the question that you are asking. It doesn't really matter what kind of data it is per se. It has to be informative and meaningful data. And I think that's really the key above anything else. Again, there's a lot of, especially when you get funding to do programs, you're asked, whether it's from the federal, whether it's from the state, some organization, they're always going to ask you to collect data and present some information. And again, some of them will actually provide you with tools and metrics, and sometimes they're absolutely inappropriate to what you're doing, yet you have to collect them. So I think you've got to do this balance between what's required, for example, from the organization that you're reporting to, and they're asking all sorts of different questions because they're coming at it from a different perspective. And perhaps before you start collecting data, what would be more useful is to sit down with all of the stakeholders and decide in advance what's going to be most meaningful, again, from the enterprise perspective, from the system perspective, not just from this narrow telehealth perspective, as to what is truly going to be beneficial for your entire enterprise and how telehealth is going to fit into that, and then decide what those questions are, and then the data can flow from that. So whether it's quantitative data, qualitative data, where you're perhaps doing focus groups with your patients, those are all very useful techniques, and you do it within your normal healthcare enterprise now. We have in our department an entire team, and it's hard to believe that radiology would need this because most people don't even think of radiology as doctors or people behind the images just get read. I don't know how they get read, but the report pops out, my primary care doctor knows it. But we actually do a lot of patient engagement and surveying about how our patients feel about their encounters. What would they have liked better or worse? It's the same thing in telehealth. They're not different questions. They're the exact same questions. And I think we've all kind of stressed that. And the data can be in any number of forms, but as often as you can, as has also been mentioned, try to utilize validated techniques, surveys, tools, so you're not reinventing the wheel. If you feel that you have to reinvent the wheel, and perhaps you are doing something that's so very different, I highly encourage you to seek out perhaps someone in your Department of Public Health, epidemiology, whatever, someone who understands how to create and validate surveys, because they can be really, really bad and totally useless after you put all that energy into doing it, and you've got data that when you go to someone and they say, well, that was a stupid question and you asked it all wrong, so who cares about your data? So again, it's not necessarily being able to say this is what you should collect. It's what fits your particular situation and how it really answers the broader question of your healthcare enterprise.
Great, really fascinating points. Bonnie, I'm going to couple the question that's been asked by an audience by the question that I was about to ask you. So as a rural health clinic, FQHC, or critical access hospital, for example, just naming some organizations, how can we demonstrate ROI for telehealth initiatives not measured in dollars?
I think everything that the panelists have talked about today are part of that. There's an echo for some reason now. Do you hear that? Okay. Because all return on investment is not financial. If you are starting a program to increase the clinical outcomes of patients with any diagnosis, then that is extremely important. I think the real challenge is for health systems and others to look at their entire process. For an example, Appalachian Regional Health, who won an award last night for their innovation in rural Appalachia, they implemented remote patient monitoring. And then in the process of that, we also worked with them to maximize the visits and maximize the revenue for patients that are discharged from the hospital coming into a clinic office. Because if you come in and have a visit within 7 days, the reimbursement is much higher than if that's at 14 days or after 30 days. So look at ways to increase your revenue. In addition to that, they implemented CMS's chronic care management program within their clinics to generate revenue that now is offsetting the cost of their remote patient monitoring program. So I think it's extremely important from the very beginning to work with your finance department, as I've said before, to clearly identify what are the goals and the objectives and how we're going to measure this. Because my experience in the last 20 years has been, no matter how good the clinical outcomes are, if you don't have that financial return on investment, you have a difficult time in scaling your program and enlarging your program. So I think, again, it's just critical that you work with the finance department along with your quality department to identify what are you going to measure, as the panelists have said before. But bottom line, unfortunately, we all know you have to follow the money.
Excellent, excellent, great point. And finally, Dr. Mrocha, if you were a state policymaker, either in legislature or medical board, given the evidence to date about direct-to-consumer telemedicine, what regulations would you put in place?
So it's a timely question in terms of some of the conversation about in Texas, Arkansas, and many other states in terms of how does one take that quality data and quality measurement and then change it, because a lot of state legislators as well as medical boards are wondering what should we do about telehealth. I think my general thought is to use the framework that the Federal Trade Commission uses, which is to say, is there compelling evidence that there is patient harm from this new care option in this particular case? If there is no evidence of compelling patient harm, don't do anything. It's anti-competitive. You're creating regulatory barriers for entry into the market. And my argument back would be that anything that you make specific to telehealth is really problematic, from being regulations about, we were talking yesterday about regulations about how you need to do a certain informed consent for a telehealth visit. That seems very silly. You should have a informed consent for all patient encounters. If you're worried about some of the antibiotic prescribing data that I'm describing, issues, well, we've had antibiotic prescribing problems in our healthcare system for 20 years. If you feel it's an issue, then every single provider in the state should be put to the same metric, and every urgent care and ED, et cetera, should be held to the same metric. If you're worried about disruptions in clinical care, which I think are an important concern with a lot of different providers, well, EDs are disruptions in care. Often an ED doc doesn't know what the information, may not get that information to the primary care physician. So if you're going to have some regulation there, it should be applied to all providers, not specific to telehealth. And I think there's always this desire, because something's new, that we should do something. And in this particular case, I would argue to do nothing unless, again, there is compelling evidence that there is patient harm.
Great. It's so awesome to have a panel that actually writes about this evidence and actually are the people that publish these articles that you can read. So another question, actually, I'm going to look at the last question, which is actually one of the questions that I've had since working at HRSA. We help rural and underserved populations with kind of the adoption of telehealth and other health IT types of initiatives. So what are some techniques that can help obtain physician and consumer buy-in in telehealth initiatives?
I think a lot of it is just education and demonstration. It's one thing to sit there and hand out a technology readiness assessment. The minute you say technology readiness assessment, right at the top, you've freaked everybody out already. And so I don't think that's a good way to address telehealth. Don't ask about technology. Don't ask, do you have a computer at home and are you willing to do Skype, blah, 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 blah. Totally wrong. Talk about a variety of options to reach out and provide care and figure out what would be best for those patients, including telehealth as one of the options. Maybe they would prefer to come in person. Find out why. What's different about it? But don't talk about everything in the terms of technology. I think that's where a lot of us have gone wrong in the past. Talk about it in terms of, you know, education and so on. In terms of buy-in, once you've got people in, what did they find attractive? What were the aspects that from their perspective as clinicians and as patients did they find was most beneficial? I think a lot of times we guide them towards the answers we want to hear. It saved travel, it saved time from work and so on. But there's qualitative methods that are out there that are very useful as well, focus groups and so on. And to try not to ask such leading questions that answer things the way we want them to be answered. If you listen to the patients and the providers sometimes, you'll find some very different things that they found were the benefits of doing telehealth, and that's what led to their buy-in that you never even thought of because you're so focused on some of the things that we've been talking about, the technology, the return on investment, and so on. So I think you have to do this mixed methods, what we call assessments, to really figure out what people are considering important in their healthcare and then fit telehealth on top of that rather than sort of this bottom-up pushing telehealth is the one thing you're trying to assess.
Can I ask a question? Can I ask you a question?
Sure.
Sorry. You know, one of the things I've seen with health systems that are introducing telehealth programs is it, in some cases, appears to be we want to specialize some of our providers to do it. So let's say it's a dermatology program. We have 20 dermatologists on staff, and these 2 are the ones who are going to do all telederm, and these other 18 aren't going to touch it. And I see some advantages of that, and then I see in other systems where it's like everyone does everything. And in some cases, I feel like the reason I'm asking you is radiology feels that way. And I was curious if you were to advise people on that specialization versus everyone doing it, which do you think works better in the long term?
I think it all comes back to human factors. It's all personality to some extent. I really think there are some personalities that are more suitable to do telehealth, teleradiology, to specialize in a certain way, and it has nothing to do with telehealth per se. You know, why does somebody become a radiologist? You know, why the heck would you sit in a dark room all day? Or a pathologist. I mean, there's a personality. There's, you know, people talk about surgeons. It's a personality. It's that type A. People go into certain fields because of what their interests are. Not everyone is suited to telehealth. I have seen, you know, people would say, oh no, we don't want to go to the older docs. They're not going to be able to do this. Let's just talk to the younger ones because they're used to video and all this technology. There are some younger docs who are just awful at telemedicine and really don't want to do it. So it has nothing to do, I don't think, with, you know, the specialty per se and saying, well, you're going to do this, you're going to do that. I think people have to want to do it and be good at it. You know, there's some people who can teach and some people who can't teach. You can get a PhD, but that doesn't mean you're a good professor.
Do you have a book? I'd like to read that. I'd like to buy your book.
I have a couple books, but yeah.
Awesome. I guess we have time for just one last question from the audience. Can you comment on the process by which investigators can access claims for data analysis, be it Medicare, Medicaid, or private payer? I think that may be a Bonnie question, I'm not sure.
Yeah, or the short answer for Medicare and Medicaid is CMS has a whole process and you go through ResDec and it's very standardized and you got to do it that way.
And most databases will cost you some money. So you need to get the grant to do research, unfortunately.
Right. Bonnie, did you have any comments or?
No, I think, again, working with your finance department is absolutely key.
I just wanted to add one point to that, which is that it's not true for all health systems. What I've been increasingly seeing is that as health systems, to the degree that this is a question directed from a health system perspective, are creating partnerships with their local health plans because they are going into risk contracts. So they're going into ACOs, bundled payment programs, and there are now the data coming into the health system about their patients. And that really creates a useful opportunity that if to use the claims there. So that's something that I think has been relatively unique over the last couple of years and might be another way of getting the data. Because I do, you know, we use Medicaid and Medicare data, but it does it's a bit of a painful process to get, and it does cost money.
Excellent, thank you. Well, that concludes today's session. Thank you so much to the panelists. We have this, excuse me, the slides are on the app, And also there's an evaluation if you could please fill that out on the MATRC app as well. So I'd like to go ahead and conclude today's session, and thank you so much to the panelists and for the audience.